Good morning, sir, and respected teacher and my colleague. Today we are discussing one journal that published in the Lancet in 2025 on pancreatic cancer. Introduction. Pancreatic cancer is a lethal disease for the most patient with a reported median overall survival of 4 months across the all stage of the disease. This poor survival is driven by aggressive tumor biology and conditions, asymptomatic nature, often resulting in late clinical presentation. As consequence, just more than 50% of pancreatic cancer present with metastatic disease at diagnosis. Early systemic spread and insufficient effect of the systemic therapy make systemic disease control challenging even in the patient with presenting with radiological localized disease. Despite dismal prognosis and small improvement in the survival for individual with pancreatic cancer, 5-year overall survival has increased over the last 30 years from 4% to 13%. Epidemiology. Among the all cancers, pancreatic cancer is the 12th in the incidence and 6th in the cumulative mortality. The global lifetime risk of the developing pancreatic cancer and death from the pancreatic cancer is 0.89% and 0.85% respectively. The incidence of the pancreatic cancer is increasing among the young adult with global age standardized incidence of 0.2% among the adolescent and young adult aged 15 to 39 years influenced by the growing prevalence of obesity. Pathogenesis. Pancreatic cancer is the most common solid tumor of the pancreas, comprising more than 95% of all pancreatic nuclei. The pathogenesis, most common somatic mutation is the KRAS. The first is the pancreatic glandular epithelium, then it converted into the pancreatic intraepithelial neoplasm 1, 2, 3. First mutation is the KRAS mutation along with the telomere shortening. Then second is the mutation in the CDKN2A, then TP53, SMAD4 and BRCA2 loss. And pancreatic cancer, there are the different types: basal-like, classical and hybrids. Tumorigenesis is entirely somatic. More than 91% somatic mutation find, but germinal mutations only 9%. Pancreatic cancer characterized by the desmoplastic stroma, which cause the elevated intratumoral interstitial pressure hampering the chemotherapy delivery. Pancreatic cancer cells extend along the vessels, nerve and collagen structure. This extending of cancer cell explain the high rate of perineural invasion, lymphovascular invasion, which are associated with worse overall survival. Risk factor: modifiable and inherited. Modifiable: pancreatitis, acute and chronic, cigarette smoking, heavy alcohol, diabetes, high BMI, and metabolic syndrome. Inherited: familial pancreatic cancer, BRCA1 and 2, PALB2, ATM, mismatch repair genes, MLH1, MSH2, MSH6, and CDKN2A, familial amelanoma mole syndrome, and Peutz-Jeghers syndrome, STK11, and hereditary pancreatitis. Screening and surveillance. Screening for the pancreatic cancer is not recommended given the low incidence and absence of the accurate screening modality. Genetic testing recommended in the high risk, that previous discussed the inherited risk factor like Li-Fraumeni syndrome, Lynch syndrome, familial pancreatic cancer, and relative with the non-pathogenic mutations. NCCN guideline 24 emphasizing that patient counseling is the crucial when surveillance is the considering the potential drawback like uncertainty about the benefits, false positive finding and cost. Surveillance aims to detect the high-grade precursor and pancreatic cancer at early stage that started age of the 50 or 10 year earlier than the age of diagnosis in the youngest affected relatives. The recommended screening modality are endoscopic ultrasound and MRI with MRCP once per year, and diagnostic accuracy of both US and MRI with MRCP are similar. Individuals at high risk with the screening detected pancreatic cancer are more likely to have early stage disease at diagnosis compared with the general population of the patient diagnosed with pancreatic cancer. Diagnosis, there are some clinical features, but pancreatic cancer typically cause the non-specific symptoms, resulting in the diagnostic delay. But there are some features that one, the dysphagia or indigestion that occur in the 21 to 21 percent people, nausea, vomiting, loss of appetite, abdominal pain, jaundice, constipation, back pain, new onset diabetic, weight loss, and figure that abdominal pain is the commonest symptoms. Diagnostic imaging modality of the choice in suspicious of pancreatic cancer is the pancreatic protocol, contrast enhanced three phase that included pancreatic phase, arterial and portal venous phase, CT, which has diagnostic accuracy of 89%. Pancreatic cancer in the head often cause dilatation of the both CBD and when pancreatic duct, that called the double duct sign. Difference between pancreatic cancer and other periopulmonary carcinoma are challenging as illustrated by the 13 to 32% preoperative misdiagnosis risk among the resected pancreatic head adenocarcinoma. Pancreatic cancer typically appears hypodense on the CT in contrast to hyperdense pancreatic neuroendocrine tumors. However, about the 5 to 17% of lesions are iso-attenuating on the CT, particularly small lesions. Absence of the visible mass. Other key finding raising suspicious for pancreatic cancer include pancreatic duct dilatation with abrupt cutoff and glandular atrophy. MRI and US can performed in the suspected iso-attenuated mass or patient with contraindicated no contrast and CT scan. MRI characterizing the liver lesion that are indeterminate on the CT and detecting the liver metastasis that are not visible on the CT. Given difference in sensitivity 83% for MRI and 45% for CT. PET done to exclude the distance metastasis in inconclusive CT or MRI or in individual high risk of metastatic disease like high elevated CA19-9, regional lymphadenopathy and large primary tumors. Pathology. Pathology needed when one is the patient is the suspecting the metastatic pancreatic cancer, localized pancreatic mass when imaging cannot differentiate between the benign and malignant disease. Third, in whom chemotherapy is considered as a first line. The endoscopic US with fine needle biopsy better as compared to the fine needle aspiration, means cytology. So genetic testing for the inherited mutation is recommended by the NCCN in all cases of pancreatic cancer, especially when tumor directed treatment considered in locally advanced or pancreatic cancer. Molecular profiling is recommended to investigate presence of actionable somatic mutation like BRCA, DNA mismatch repair gene and KRAS. Laboratory serum CA19-9 and CA liver enzyme bilirubin are measured in the patient with suspected pancreatic cancer. However, CA19-9 inaccurate for diagnosis, screening or to differentiate from the other pathology because CA19-9 also elevated in both benign as well as malignant pathology. 1/3 of the pancreatic cancer have non-elevated CA19-9, including the 8% who are the non-secretory of CA19-9. The liquid biomarker with a higher diagnostic accuracy than CA19-9 are not available now. CA19-9 is valuable in the proven pancreatic cancer as an indicator for micrometastatic disease, risk assessment for occult metastasis, and treatment response evaluation. Staging laparoscopy. Staging laparoscopy done before the initial treatment with chemotherapy or before surgery to detect the occult metastasis. Staging laparoscopy yield to detect the occult metastasis has decreased from 20% previously, now in the 15%, but due to the improved cross-sectional imagings. Staging laparoscopy considered in the patient with high-risk feature like indeterminate extrapancreatic lesions, strong elevated CA19-9, large tumor, pancreatic body or tail cancer, borderline, and pancreatic cancer with ascites. Staging: approximately 57% of the pancreatic cancer with metastatic disease at time of diagnosis. With cancer predominantly metastatic sites are liver, then peritoneum, then lung, then extrarenal lymph nodes. In absence of metastasis, pancreatic cancer is anatomically staged at resectable, borderline resectable, and locally advanced, depending on the presence and extent of involvement of peripancreatic major vessels like superior mesenteric artery, celiac axis, hepatic artery and its branches, and portomesenteric venous plexus. So this is the figure that showing the resectable, borderline resectable, locally advanced, and metastatic on basis of the superior mesenteric, celiac axis, common hepatic, and portomesenteric venous axis. Resectable when that lesion is the not involving the SMA, celiac axis, or common hepatic artery, but less than 180-degree contact without vein contour irregularity. It resectable. Borderline: less than 180-degree contact with SMA and celiac axis, and any contact without extension to celiac artery or hepatic artery bifurcation, or in portomesenteric less than 180-degree contact with vein contour irregularity, or more than 180-degree contact without vein contour irregularity or thrombus, or without reconstructible or any contact with IBC. Locally advanced: more than 180-degree contact with SMA, celiac axis, or any contact of celiac artery with aortic involvement, or any contact with the extension to the celiac artery and or hepatic artery bifurcation, and no reconstructible involvement due to the tumor contact or occlusion. Occlusion means thrombus. Metastatic to a distant site. So resectability criteria according to the NCCN guidelines are most commonly used. Besides this main technical classification, TNM classification of the AJCC used for prognostication, that based on the imaging, and after resection based on histopathology. Staging could be done within the 4 weeks before initiation of the treatment and before the biliary drainage. Clinical staging further improved by the taking tumor biology and patient conditions with WHO performance status, that called ABC nomenclature. When CA99 not elevated, CEA and CA125 can be used. In cholestasis, CA99 measured after the normalization of the bilirubin and close to initiation of the tumor-directed treatment for the adequate staging and response evaluation after chemotherapy. An observational study showed that anatomically resectable pancreatic cancer with biology-based borderline resectable uh, disease, means CA99 more than 500, treated with the upfront surgery associated with the impaired overall survival. This supported by the another study, localized pancreatic cancer, who started with the modified FOLFIRINOX as a first-line treatment in anatomical borderline resectable pancreatic cancer and locally advanced pancreatic cancer, biological CA99 more than 50, and performance status more than 1. These factors at a diagnosis are the poor prognostic factor, means these factors having the less 5-year overall survival compared to those who doesn't having the that favorable ABC. Treatment decision making is the primarily driven by the stage at diagnosis, and this figure is showing the management. So first, in the on the basis of the clinical feature, imaging, triple phase CECT pancreatic protocol with lab investigation, liver enzyme, and CA99, and pathology by the, if needed, the US FNB. Then staging, then multidisciplinary evaluation. If resectable, resectability at two category: biology, ABC biology is the good, then upfront surgery. If poor, then neoadjuvant chemotherapy. Borderline and locally advanced, underwent for the locally neoadjuvant chemotherapy and induction therapy. Metastatic for the metastatic treatment. We will discuss later. metastatic pancreatic cancer first. There are some study, they are telling the first line treatment and second line treatment for the metastatic pancreatic cancer. That Prodigy 4, it is comparing the folfirinox and gemcitabine based chemotherapy in both arm in the showing in patient with the metastatic pancreatic cancer, first line treatment with the folfirinox is the superior to the gemcitabine for the prolonged overall survival and 1 year overall survival. Another study by the Von Patel, they are that selling gemcitabine plus nab-paclitaxel and gemcitabine. They are the comparing. So in metastatic pancreatic cancer, first line treatment with the gemcitabine nab-paclitaxel is the superior as compared to gemcitabine, considering for the prolonged overall survival, but with increased rate of the peripheral neuropathy and myelosuppression after the gemcitabine plus nab-paclitaxel. And that Napoli 3 trial, they are comparing the nanoparticle liposomal irinotoxin 5-fluorouracil oxaliplatin with the gemcitabine nab-paclitaxel. To first line treatment with the nanoparticle based nanoparticle based irinotecan for 5-fluorouracil and oxaliplatin is superior to the gemcitabine nab-paclitaxel for the prolonged overall survival and 1 year survival rate, but similar rate of the serious adverse event and comparison with the folfirinox is not available. And for the second line therapy, the Polo trial, they are comparing the maintenance olaparib as compared to placebo. The patient metastatic pancreatic cancer who are the non-progressive after 4 months of the first line platinum-based chemotherapy but having the BRCA positive. So they having the maintenance therapy with the olaparib resulting in the prolonged progression-free survival, but olaparib did not result the prolonged the overall survival. Another Napoli 1 trial, there the metastatic pancreatic cancer, then including including the gemcitabine based chemotherapy. So nano liposomal irinotocan and 5-fluorouracil with leucovorin versus the nano liposomal irinotocan versus the 5-fluorouracil plus leucovorin. Results are in the disease progression, including the metastatic cancer after first line gemcitabine chemotherapy, second line treatment with the nano liposomal irinotocan and 5-FU with leucovorin is the superior to 5-FU with leucovorin, considering the prolonged overall survival with manageable safety profile. Another Prodigy 65, they are the included the metastatic pancreatic cancer who progressed during or within the 3 months after the first line folfirinox. So they compare the gemcitabine paclitaxel versus the gemcitabine. So the result who completing after first line folfirinox or were intolerant to this regime, second line treatment with the gemcitabine paclitaxel doesn't improve the overall survival as compared to gemcitabine alone. And localized pancreatic cancer, it primarily treated by the multimodality treatment. That uh, cornerstone of the treatment is the surgery plus chemotherapy. Timing of the chemotherapy and chances for the surgery depend on the tumor resectability. In resectable pancreatic cancer, upfront surgery followed by the 6-month adjuvant chemotherapy is standard of care, as randomized controlled trial have not shown the superior overall survival with use of neoadjuvant chemotherapy. Randomized trial on the neoadjuvant therapy versus the upfront surgery, but designed based on purely tumor anatomy based resectable criteria. In shift now toward the ABC approach, 2024 NCCN guideline also provide the option to treat resectable pancreatic cancer with neoadjuvant therapy, including the high-risk ABC disease feature like large primary regional lymphadenopathy, mark elevated CA 99, and excessive weight loss, which at least might reduce the risk of the futile surgery. In resectable pancreatic cancer, rate of resection after neoadjuvant therapy is 77%. After the upfront surgery, preferred adjuvant regime is modified folfirinox, gemcitabine, capecitabine, and in Asia, S1 regime. Although 24 NCCN guideline consider to use adjuvant chemoradiation to benefit on the overall survival, showing by the RCT is conflicting. The next in table we will discuss the uh, uh, three randomized control phase 3 trial on the adjuvant chemotherapy. After the pancreatic cancer surgery, approx 33% of patients do not receive the adjuvant chemotherapy mainly due to impaired functional recovery caused by the surgical complications. This omission might have less or no effect in the patient who already received preoperative chemotherapy, but clearly worsen survival in the individual who undergoing upfront surgery. The population and the study upfront surgery with or without adjuvant chemotherapy. That CONCO 01 study, they are the comparing the patient who are resectable pancreatic cancer who underwent surgery by R0 or R1 resection, then they divided into either adjuvant gemcitabine or no adjuvant. So then adjuvant gemcitabine is superior to the no adjuvant therapy considering the prolonged DFS and 5-year DFS, also OS, but therefore no adjuvant gemcitabine is the preferred in the patient undergoing the upfront surgery for localized pancreatic cancer. And upfront surgery followed by a different adjuvant chemotherapy regime, that spec 4, they are the comparing the adjuvant chemotherapy gemcitabine plus capecitabine versus the adjuvant gemcitabine alone. Primary endpoint is the overall survival. Adjuvant gemcitabine capecitabine is superior to the gemcitabine for the prolonging survival with 5-year overall survival. So gemcitabine plus capecitabine is preferred over the gemcitabine alone as a adjuvant regime following upfront surgery for localized pancreatic cancer. However, trial comparing the gem plus cap with either M folfirinox or gem nab gemcitabine nab paclitaxel are not available. Then Useka et al. They are the comparing the adjuvant S1 versus the adjuvant gemcitabine. Adjuvant S1 is the superior to the gemcitabine considering the prolonged OS and 5-year OS. Therefore, S1 is the preferred regime over the gemcitabine and adjuvant regime in the Japanese peoples only, because this trial done in the Japanese. Next is the Prodigy 24. They are the comparing the adjuvant modified folfirinox versus the adjuvant gemcitabine. So adjuvant modified folfirinox is the superior to the gemcitabine for the prolonged overall survival in 5-year survival. So modified folfirinox is the preferred over the gemcitabine adjuvant regime in the fit patient after upfront surgery for localized pancreatic cancer. However, they are also not comparing the modified folfirinox with either gemcitabine plus nab-pacli or gemcitabine plus capecitabine. Then Tempero et al. They are comparing the gemcitabine nab-pacli plus gemcitabine alone. So the results are adjuvant gemcitabine nab-pacli did not improve the DFS compared to the gemcitabine alone, although overall survival is the prolonged after gemcitabine nab-pacli. Based on the prolonged OS, gemcitabine nab-pacli would be considered as a preferred adjuvant treatment regime in the fit compared with the gemcitabine. However, they are also not comparing gem nab-pacli either with the modified folfirinox or gemcitabine. So then borderline resectable pancreatic cancer, neoadjuvant chemotherapy with or without radiation followed by surgery, and eventually adjuvant chemotherapy to complete 6-month chemotherapy. Red, randomized controlled trial shown superior overall survival with neoadjuvant therapy compared with upfront surgery followed by adjuvant therapy. However, evidence is inconclusive about the optimal neoadjuvant chemotherapy regime and number of the chemotherapy cycle and benefit of subsequent adjuvant chemotherapy. The resection rate after neoadjuvant therapy for borderline resectable pancreatic cancer is 61%. Locally advanced pancreatic cancer are primarily treated with systemic chemotherapy for 4 to 6 months, and most common regimes are modified folfirinox that we will discuss earlier and gemcitabine nab-paclitaxel. However, randomized phase 3 trial on the different chemotherapy regime for neoadjuvant or induction therapy in the localized pancreatic cancer are still not available. The three-phase, two randomized controlled trials show similar overall survival between the neoadjuvant and induction modified FOLFIRINOX and gemcitabine nab-paclitaxel for localized pancreatic cancer. Preliminary published result from the PREOPANC2 phase 2 phase 3 trial found that neoadjuvant FOLFIRINOX did not improve overall survival compared with gemcitabine based chemoradiation in borderline resectable pancreatic cancer. In subset of the locally advanced pancreatic cancer who are candidate for surgical resection after induction chemotherapy, evidence is inconclusive, particularly about the optimal number of cycle and benefit of subsequent adjuvant chemotherapy. About 22% of locally advanced pancreatic cancer undergoes resection after induction chemotherapy. The resection rate of the borderline resectable pancreatic cancer and locally advanced pancreatic cancer after systemic chemotherapy are lower in the population level due to referral bias. Current guidelines allow for the possibility to administer additional chemo or radiation after the neoadjuvant or induction chemotherapy, including the SBRT, which allow to precise and therefore high dosing compared with conventional EBRT. Radiotherapy, that radiation associated increased rate of microscopically radical resection and pathologically complete response rate. Randomized control trial, however, have not shown a survival benefit for adding the pre-op radiation. Moreover, Alliance A 021501 phase 2 randomized control trial showing longer 18-month overall survival after neoadjuvant modified FOLFIRINOX alone compared with modified FOLFIRINOX plus hypofractionated radiation in patients with the borderline resectable pancreatic cancer. Response evaluation after chemotherapy is challenging due to inability to differentiate between the key tumor tissue and fibrosis on the CT scan, illustrated by sensitivity and specificity of CT scan to predicted on R0 resection 78% and 60% respectively. Excluding the disease progression and metastatic disease is a main radiological parameter assist at restaging. Poor ability of CT scan to differentiate between the tumor tissue and fibrosis underlines importance of an ABC approach at restaging. CA99 concentration need to be stable at least after the neoadjuvant therapy for the patient with borderline resectable pancreatic cancer, where a substantial decrease after induction chemotherapy is required in locally advanced pancreatic cancer according to the NCCN 24. Diverging target for the sufficient CA19-9 response are described either based on the relative response or absolute concentration at restaging. PET-CT before and after chemotherapy used to assess the biological disease response, particularly in non-elevated CA19-9 at diagnosis. Considering complexity, treatment decision making are done by the multidisciplinary tumor. Surgery with systemic chemotherapy provide the best chance to achieve the long-term overall survival. However, after the surgical resection, 5-year overall survival is still only 17% due to high locoregional and distant recurrence. 48% at 12 months that recurrence and 86% at 5-year postoperatively. Predicting the early recurrence is difficult at presence of unfavorable parameter does not preclude long-term overall survival. Most common resection is the pancreaticoduodenectomy followed by the left side pancreatectomy, that distal pancreatectomy and total pancreatectomy. The pancreaticoduodenectomy associated with the 19-day major morbidity rate 26% and mortality of 5%. Lower failure to rescue rate is seen in high volume center with experienced multidisciplinary team and round clock interventional radiology and interventional endoscopy services. Pancreatic cancer surgery might require the portomesenteric venous, arterial, and multivisceral resection to obtain a radical resection. Therefore, centralization of pancreatic cancer surgery is highly advocated. Higher hospital volumes are associated with lower surgical mortality. Pancreatic surgery is associated with endocrine and exocrine insufficiency in respectively 20% and 43% after pancreaticoduodenectomy, 23% and 12% after distal pancreatectomy, and 100% after total pancreatectomy. Open surgery by laparotomy, standard of care, but minimal invasive surgery, either laparoscopic or robotic assisted, is increasingly used in the patient without vascular involvement, as minimal invasive surgery might enhance the functional recovery and the feasibility and safety of the laparoscopic pancreatic surgery compared with the open approach, specifically for pancreatic cancer, has been the shown for pancreaticoduodenectomy and distal pancreatectomy, where where a level 1 evidence for robotic pancreatic surgery is awaited. Local ablative therapy. Local therapy studied in the locally advanced pancreatic cancer after induction chemotherapy in whom extensive vascular involvement, poor tumor biology, poor performance status preclude the surgical resection. International guideline purpose to consider the palliative chemo RT to achieve the local disease control. Ablative radiation include SBRT has shown promising locolesional control and survival, but level 1 evidence is awaited. Randomized control found no survival benefit for irreversible electroporation and radiofrequency ablation in the locally advanced pancreatic cancer. Supportive care are comprises of multiple domains including the management of pain, nutrition, rehabilitation, biliary and duodenal obstruction, and quality of life and psychosocial support. Abdominal and back pain is up to 62% in the patient before diagnosis. This pain causing the multifactorial including the perineural invasion, ingrowth into surrounding viscera, and metastasis that requiring the multidisciplinary evaluation. In case of the pharmacological therapy insufficient to control tumor related pain, intervention like celiac plexus neurolysis when life expectancy less than 3 months, or radiation when life expectancy is the more to be considered. Screening for the malnutrition should be standardized, at approximately 63% of the patients with pancreatic cancer have cachexia at diagnosis. Prehabilitation, including the physical training, dietary consultation, is important to prepare the patient for tumor targeted therapy. APA cap, this is the one randomized trial in advanced pancreatic cancer, show the positive effect of adaptive physical activity training to the global health status, functioning, and symptoms without effect on chemotherapy treatment and survival. A contributing factor to development of weight loss and cachexia is pancreatic exocrine insufficiency. Pancreatic exocrine insufficiency occur in 72% of patients with advanced pancreatic cancer and requiring the pancreatic enzyme replacement therapy. According to the 24 European guidelines, however, standard approach regarding the malnutrition screening, dietary consultation, pancreatic enzyme replacement is often missing in daily clinical practice. Considering the high incidence of exocrine pancreatic insufficiency in pancreatic cancer, especially when located in pancreatic head, and diagnosis of exocrine insufficiency made on the symptoms like diarrhea, steatorrhea, bloating, abdominal cramps, and flatulence, and nutritional status alone. Malnutrition can caused by the gastric outlet and duodenal obstruction, which managed with the surgical or endoscopic gastrojejunostomy. After the securing the biliary drainage, and gastrojejunostomy is typically superior to the duodenal stents. In patients with the cholestasis, biliary drainage advised who schedule for the neoadjuvant or induction therapy, having the delay of the upfront surgery for more than 2 weeks, having the symptoms of the cholangitis or fever, or having the severe symptomatic jaundice. Biliary drainage preferred by the endoscopic ERCP with SAMS stenting at compared to the plastic stent because they are the longer in patency. Diabetes prevalence 30% in the general population with pancreatic cancer, and diabetes recognized and managed in this group of the patient. In addition, new onset diabetes might occur after the pancreatic surgery. Management of the diabetes after total pancreatectomy is the particularly challenging with a negative effect on the quality of life. However, long-term quality of the life outcome of the total pancreatectomy are similar as compared with the patient undergoing the partial pancreatectomy. Psychological support is the relevant considering the high prevalence of the depression, anxiety of the patient with the pancreatic cancer. Future directions. The further improvement in the pancreatic cancer are to be needed. First, whether tumor marker of the improved accuracy are needed for the early disease detection, assessment of the treatment response, patient selection and prognostication. Circulating tumor DNA has shown promising result, but being associated survival at time of diagnosis or after treatment. Pancreatic cancer in had often required the biliary drainage through ERCP. However, ERCP results in acute pancreatitis in approx 10% and cholangitis approx 3% of patient, which might worsen the patient condition and delay neoadjuvant chemotherapy or upfront surgery. US guided transduodenal biliary drainage is alternative to the ERCP stenting can avoid the acute pancreatitis. Meta-analysis show that US guided biliary drainage was associated with lower stent dysfunction, similar technical success rate and no pancreatitis, but this approach has not yet included in international guidelines. US guided gastrojejunostomy for the gastric outlet or duodenal obstruction alternative to the surgical gastroenterostomy. Results are awaited from the randomized controlled trials investigating the value of neoadjuvant therapy for resectable pancreatic cancer and optimal neoadjuvant and induction therapy for borderline resectable and locally advanced pancreatic cancer. These trials assess the various strategies including total neoadjuvant therapy, optimal number of the cycle of chemotherapy, different multi-agent chemotherapy regimes, adding value of radiation. However, randomized controlled trials are needed to investigate value of the second line neoadjuvant or induction chemotherapy in patients with biological or radiological locoregional disease progression. Even though one-fifth of the patients diagnosed with the locally advanced pancreatic cancer are resected after modified fulfurinax or gemcitabine nab-paclitaxel with 5-year OS up to 20 to 25%, survival benefit of subsequent surgery remain unclear. Pancreatic resection are increasingly performed mini-invasive surgery minimal invasive surgery. However, evidence about the robotic assisted surgery, specifically in the pancreatic cancer, is awaited. An indication and selection criteria of minimal invasive surgery in pancreatic cancer remain a topic of debate. Subset of the patient present with the synchronous oligometastatic disease, mostly defined as having 3 or fewer metastatic lesions in liver, lung, or both. Highly selected patients might benefit after extensive chemotherapy from the loco-regional treatment like radiation, resection, ablation of metastatic lesion, eventually combined with resection of the primary tumor with a reported mean overall survival 16 months. The randomized phase 2 trial show a benefit of metastatic directed therapy with systemic chemotherapy compared with the systemic chemotherapy alone in the patient with the oligometastatic pancreatic cancer. Median progression-free survival was 10 months versus the 3 months. Target therapy for the pancreatic cancer remain major challenges. The next table, they are showing the clinical phase 3 trial on targeted therapy for pancreatic cancer, but none of trials showing the survival advantage. So clinical trials should be determine the adding value of the routine genetic and transcriptome tumor profiling like basal-like versus classical subtypes, SMAD4, BRCA and GATA to determine the sensitivity and specific chemotherapy regime given the growing evidence suggesting a difference in the chemosensitivity between the tumor subtypes. Pancreatic cancer is called immunologically cold tumor, wherefore previous immunotherapy trial did not show prolonged survival except for the less than 1% of the patient who had the DNA mismatch deficient tumor, for which immunotherapy with checkpoints inhibition lead to promising survival. However, there are the first signs that this dogma might to be broken in the future with novel generation immunotherapies in combination with chemotherapy and radiation. Further, mRNA-based individualized neoantigen-specific and dendritic cell-based immunotherapy in the adjuvant setting. There are some study that agent for the extracellular matrix targeting checkpoint inhibitor, tyrosine kinase inhibitor, but none of study they are the improving the survival benefit and antimicrobial agents. The conclusion: pancreatic cancer is the high lethal disease due to its aggressive tumor biology that frequently present with non-specific symptoms and high rate of metastatic disease at diagnosis. Multidisciplinary approach is mandatory to stage and treat the pancreatic cancer with tumor-directed therapy and concomitant supportive care. Chemotherapy and surgical resection is the cornerstone of treatment, but only a small subset of the patient are candidate for surgery. Given prospect that pancreatic cancer will become the second leading cause of the cancer-related death by 2030. There is urgent need for the novel tumor-targeted therapy with promising results from the new generation immunotherapy and KRAS-directed therapy.